Hello, 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 everyone. Welcome again to another Center for Black Equity Community Conversations. Um, Everyone knows who I am. My name is Kenya Hutton. I am the Deputy Director here at the Center for Black Equity, and I'm going to bring on my amazing co-host, Tony Marie Preston. Hey, Tony.
Hey,
How are you?
I'm great. How are you?
I'm pretty good. I'm pretty good. Clearly, you can see already I'm having some internet issues, but we're going to push through and we're going to persevere because that's what we do,
Yes, of course.
right? Um, I'm excited about today's conversation again. I feel like I said it all the time, but I'm really excited about this.
Me
Uh,
too.
because this is really like the future, right? Of,
Mhm.
of our community, of our health, of HIV prevention and treatment. This is really the future of where we're gonna go. So, without further ado, I'm gonna start bringing in our guests. All right. All right. First up, we have Dr. Stephaun Wallace. Hey,
Hello,
Stephaun.
hello.
How are you?
I'm awesome. How are you?
I'm pretty good. Pretty good. Can't complain. For I mean, everyone knows who you are, but for those people that don't, tell them a little bit about yourself.
Um, I'm a PhD level epidemiologist. I'm involved in HIV and COVID-19 vaccine research globally. And I am also the grandfather of the new house of Mark Jacobs.
Oh, that's right. Congratulations on that move and welcome, welcome, welcome.
Thank you.
All right. So next up, we have Mr. Martez Smith, and I'm gonna let him introduce himself. Martez, how are you?
I'm wonderful. How are you?
I'm pretty good, pretty good. Can't complain. Same thing for you. For the people that don't know who you are and the great work you're doing, tell us a little bit about yourself.
Okay. So my name is Martez Smith. I currently reside in New York City, Harlem to be precise, by way of Columbus, Ohio. I'm currently a PhD candidate in nursing and health science at the University of Rochester School of Nursing. My dissertation focus, my larger research focus in general, is really centered around the experiences of Black MSM, Latinx MSM, and sexual health, and how that relates to HIV and STI prevention, treatment, and care. In addition to my research, I'm also one of the co-founders and currently the executive director of the Keeping Ballroom Community Alive Network, also known as KBCAN. And what we do is we provide a variety of capacity building and leadership development services to LGBTQ folks of color, ballroom community members to be specific. So, but our services are open to a larger community. So
Awesome. Come on, some. All right. You know what? As y'all were talking, you know, this is a whole ballroom panel tonight. So talk about ballroom excellence going on tonight. I'm a garçon, Tony's a garçon, Stephaun's Mark Jacobs, Caroline Vaughn. Come on, ballroom excellence. Let's show them that ballrooms have smarts too, right? We have brains. We're more than
yes,
just
yes, yes,
whatever
yes.
people see. Yes. All right. So, everyone that's watching, if you have a question or a comment or a suggestion or anything, feel free to put it in the box, in the chat box, whatever streaming platform, whether it's on YouTube or Facebook, and we will get the questions to our panelists and hopefully get it answered. So, to start off real quick, just to set the tone. So let me back up. So I posted the flyer on our social media platform a few weeks ago. And I've been reading the comments that's been coming under it. And I don't think people really understand what biomedical intervention means. So if you guys can talk about that, what does it mean? What is biomedical HIV prevention or biomedical treatment? What does the whole concept mean?
Martez, did you want to go?
Yeah, sure. So the entire concept of biomedical prevention is essentially bio means life and medical, right, means to render medical care. And so we're using technological advances in medicine to prevent something, right, whether that be sexually transmitted disease or infection, or whether it be something like a respiratory infection like COVID, right? So that's just the basic premise of a biomedical intervention. So I would say more, but I don't want to be, too overbearing with the discussion. I want a little bit more. I want y'all to, probe.
I want to add though that I think a lot of people think about biomedical interventions as it relates to HIV and COVID, given where we are with the pandemic and so much conversation that's happening, particularly in our communities, about HIV. But truly, high blood pressure medication is a biomedical intervention.
Right.
Asthma pumps are a biomedical intervention. So there are lots of biomedical interventions that exist, and they were brought forward because of research and from people participating in that research.
Okay, awesome. Thank you for that. Thank you both for that explanation. I hope that answers some questions, because I just been reading and I've been reading it. I haven't responded because I was like, I'm going to wait for you all, the experts, to talk about that. But I realized people don't know when you said biomedical intervention, they don't know what that means, and they go on this whole like biohacking and changing this, and it like, I kid you not, that thing went so many different directions. So thank you all for like giving like a really easy, succinct definition of what it means. All right, so PrEP, right, is something that we've had around for quite some time now, right? And there's been different communities that been good at uptaking it. Some have struggled, but what we notice is that, or what we've been told is that really MSMs, especially Black queer folk, around the ages of 16 to 21, seem to not be getting on PrEP as much as the other populations. So the first question that we got sourced, and just for everyone watching, the questions that we have sourced came in from like memberships, community, stat, came from a group of people, right? So the first question that came up was, what are some of the barriers for PrEP engagement with MSMs 16 to 21 years old?
Where do we start? Look, and that's a broad question. I'll say this much. I mean, it depends on which group of MSM you're looking at, right? In terms of race and income and where you actually live geographically, right? So just off the bat, right, if you live in an urban epicenter, right, or like you just simply being close to a prescriber who prescribes PrEP, right, who knows what PrEP is much higher. If you live in a rural environment, right, you might have to drive a ways to get to your nearest medical provider. And then there's also a decent amount of stigma that exists on there just around HIV, let alone PrEP. And other biomedical interventions when it comes to that. So, but then when you look at this by race, right, Black MSM in comparison to Latinx and white MSM are utilizing PrEP at much lower rates. And that's for a myriad of reasons, despite increased access. You could look at racialized discrimination, right, and just the simple day-to-day, like the quotidian, right, the ways that Black men exist, right, and how they experience reality, having to fend off discrimination. If you live in, right, urban ghettos or poor areas of low socioeconomic status, right, you compound that with police violence, lack of resources, right. Does that to say a few, right, and then there's that, couple that with provider mistrust. There are provider level factors, institutional level factors that also prevent folks, of various, demographics from accessing PrEP. So,
okay. Anything you want to add to that?
I would just add that there are so many, and Martez covered quite a few. And I tend to think about this. Some folks have done some amazing work looking at, barriers and facilitators for us in terms of our health and our health outcomes as community folks, right? And they've looked at this across different levels, and using different kinds of models. One of the models that I really enjoy examining this with is the social ecological model, which really looks at sort of what are we doing at an individual person-to-person level, right? What are we doing at a community level? What are we doing at an institutional organizational level? And what are we doing at a policy and society level? Mm-hmm. And so many of the points that Martez raised hit across those levels. And I would also argue to say that that there are some people who are just not socialized around taking medication daily. And for them, this is just not, something that they're interested in doing. Right. And so, as we continue to think about other ways of introducing pre-exposure prophylaxis to people and other ways of providing the medication, injectable as an example, I think that will provide additional options for people that they may consider, in addition to the barriers that were raised.
Okay. Awesome. Thank you. Thank you. Tony, do you have any follow-up question or anything to that? Got it.
So the follow-up question for that is, just kind of like given some of the healthcare barriers, like you spoke of, accessibility, or medication, adherence, what are some of the barriers that you believe are kind of like experienced by most vulnerable populations, and why I
I
provided
think the
to discuss intervention?
Yeah, I think that some of the challenges that exist, and Martez spoke to this a bit, is that there's a huge amount of bias in the healthcare system. That
Mhm.
there are some folks who are actively working to change this, to change the climate of this, right? But much of this is decades, if not centuries, old. And it
Mhm.
has remnants that date back to even some of the origins of gynecology and some of the origins of other kinds of medicine in this country. So thinking about how racism has been entrenched and really supported and helped to move forward, and also in many ways provided a barrier for us to be engaged fully for centuries. Some of these issues still exist. And it doesn't, for many people, they think that, if you make enough money, if you live in a certain kind of neighborhood, if you have a certain kind of job, then somehow you'll be able to escape all of the negative health outcomes that exist in our communities. And the research just continues to show that that's not true.
Right.
You can't out earn, racism, in this country, right? It's so pervasive. So that exists also in the medical system. And so engaging folks in medicine means that providers generally may not be likely to have conversations in depth about your sexual health generally, irrespective of whether or not it's about PrEP or contraception or even treatment if you're a person who's living with HIV. So, thankfully there's some people out there who are working to change this within the system so that more people have access to providers who have the capacity to engage in these conversations in really meaningful ways. But I just think we need to continue to work at it. And if people have issues engaging their healthcare providers around these conversations, to note that many healthcare systems have advocacy avenues that patients can take in order to address their grievances. And walking away from situations and systems that continue to perpetuate oppression and racism are actually not supporting our collective health and our collective good.
Come on, Juan, you said a word. Oh, shout out to our social justice warriors out there doing the good fight. Um, huh. Okay. I mean, yeah, that was like such a well-rounded answer. Like that was a perfect answer to that question. So information about biomedical interventions and when it comes to like HIV prevention, HIV treatment. Um, I guess since in this question, I want to know: should the information be spread to everyone, or should the information be prioritized to heavily affected groups heavily affected by HIV? What's your thoughts on that?
Well, I'm a big yeah, I had to go first. I'm a big proponent of comprehensive sexual health education, and so I think this information needs to be spread to everybody. I mean, you like incorporate a little bit of like social theory in there. We don't live insular lives, right? This also is directly related to the socio-ecological model, or Bronfenbrenner's socio-ecological theory. We don't live these insular lives that aren't impacted by individual relationships, relationships to larger neighborhoods and communities, relationships to institutions, and large relationships to laws, right? These are things that we interface with and interact with every moment of every waking and sleeping moment of our lives. And to that extent, right, all those systems, people, places, neighborhoods, and communities, right, need to be well informed of health resources, right, of information that can help them live longer, healthier lives. Now, I think on the other hand, I definitely think advances in biomedical interventions, right, should be prioritized for folks living with HIV, especially if they're effective, right? But that shouldn't stop the larger project of educating the larger public about these advances and about this information.
And I think it's about sensitizing and the broader context for me about this is, educating to ensure that people have the information. I think about PrEP as an example, oral daily PrEP as an example, and how I will talk to Black women that I meet in different places around the country. And particularly 5 years ago, people were not having any awareness of PrEP.
Mm-hmm.
And, largely it's because, the messaging wasn't directed at them. So when we situate the education and the marketing and efforts to, raise awareness about these products, and we only focus them in specific communities because those communities, and rightfully so, have a prioritization because of the impact, we're losing the battle regarding destigmatizing HIV, because we're also simultaneously saying, without saying, that only these folks over here need to be concerned about HIV. So it's really important that the message get out to everyone, that we do as much as we can to destigmatize HIV and help people to understand that this is not a health condition or disease that only impacts one kind of person.
Right. It's so funny you mentioned that, because it's true. A couple of years ago, I was talking to a family member about PrEP, and they had no idea what I was talking about. Mm-hmm. They was just like, oh, Kenya's always in some like something else. So they was just like, oh, whatever. And then she saw it on a bus, and she was excited. She's like, oh my God, Kenya told me about this a couple of years ago. And look at it now, and I'm like, see, I told you. I told you this stuff. Like it's out there. It's out there for all of us. But you're right, because it was. She thought it was just a Black gay men's thing, and she didn't even, for whatever reason, her healthcare provider didn't even engage in her in the conversation about PrEP. Like when I brought it up to her, I might as well have been talking French to her. She had no idea what I was talking about. And then she saw it on a bus driving by, and she was like, oh my God, this is what Kenny was saying. But that's a whole nother conversation about information should be shared to everybody, because, you never know. She could have had a friend that was part of the community that she could have recommended it to. You know what I mean? Right. And I was having a conversation with a funder recently about providing some services to people, and they were like, well, how do I know it's getting in the right hands? And I was just like, it's not about getting in the right hands. You may not be the person that needs that service, but you may know somebody, right? So we don't want to like lock ourselves, like only these people should get it. No, we should everybody and let it work its way out. So anyway, yes. Kudos, I agree with everything. Tony, you want to take the next question?
Sure. So how can or will new HIV biomedical interventions promote harm reduction and reduce health disparities within the Black LGBTQ plus community?
There's a couple of different ways that I think this question can be responded to. Honestly, from a research perspective, I guess I'll start there. As products are being researched and they're going through the whole research process, the idea that we're working more intentionally to ensure that members of our communities are being included as participants in research, as well as folks who are driving and leading research studies, is critical. The National Medical Association, through their Project Inform and Impact initiative, some years ago put out a statement based on an analysis that they did that suggested and stated that part of the reason why our communities, Black communities in particular, face some of the health disparities that we do is because we are so underrepresented in clinical research. And that is clinical research that develops the data, that develops the information that helps to inform product development and how products move forward, et cetera. So if we're underrepresented in the space, meaning that there's not enough of us in there that even represents our population size, that means that this data is largely not capturing our lives, our lived experiences, like who we are as people. Mm-hmm. I even think about the reality that if you look at many of the medications that are available over the counter in pharmacies, the clinical trials to move those medications forward so that they're available to anybody, even people in our community, that those trials largely did not include us. So I think it's really important that, in order for us to really get a handle on the health disparities that impact our communities, we need the data. And how we get that data is through clinical research. And part of how we ensure equity and anti-racism, anti-Black racism lens in the process is to ensure that we're working with researchers who have our perspectives and our lived experiences in mind. And/or we're also working with people in our community who are leading and guiding these research studies.
Thank you. Martez?
Yeah, I agree wholeheartedly. Can you just flash the question up there one more time? I had like a
Sure.
question. So yeah, how can new biomedical interventions promote harm reduction and reduce health disparities? So one of the things about harm reduction and one of the things about just interventions, right? Just outside of the research context, right? Just in the real world, like you think about PrEP, or even treatment as prevention, right? Because treatment as prevention is technically a biomedical intervention, right? That's making sure folks are engaged in care and adherent to medications so that they're undetectable, thus unable to transmit the virus to their sexual partners. Just that act, right? Folks are more, by being on PrEP or by being adherent to medications, you're more engaged with the healthcare system, right? Than you would be if you weren't, right? So you kind of think about that socialization around, right? Just getting used to the idea of even engaging with the medical care system, right? That helps. In terms of PrEP, what they've actually found is that folks who are on PrEP aren't necessarily taking greater risks than folks who aren't on PrEP, right? What we do is we market PrEP as an additional tool that folks can have in their arsenal of sexual health and HIV prevention, HIV/STI prevention toolkits. So I think those are another lens to kind of look at things as well.
Okay, awesome. Thank you for that. Thank you for that. So it's so funny because I think y'all answer the question that's coming up shortly, but I'm gonna let it ride. All right, the next question is: what recent or upcoming studies or research should public health professionals and community members know about? Where can we find this information and disseminate? So what's on the horizon? Y'all two at once. I know Stephaun always keeps me abreast of everything that's going on.
I mean,
there's so much happening.
Yeah, that's like where to start.
I mean, we're still in the COVID space. A few developers have submitted their applications for licensure to the FDA for COVID-19 vaccines. There are COVID-19 treatments that are moving forward toward licensure as well. I know we just recently launched in my organization an HIV mRNA vaccine study. So very excited to look at how we took lessons learned from our prior HIV work to inform our COVID-19 vaccine work, and now taking lessons learned from our COVID-19 vaccine work and applying it to our HIV vaccine work.
Yeah, that's I'm super excited about that. I'm really excited to see some of the trials again that use like the mRNA technology, especially some like the vaccine prevention trials. So, and speaking of vaccine and prevention trials, you can actually go to the HBTN is the HIV Vaccine Trials Network, and then HPTN is the HIV Prevention Trials Network. If you go to either one of their websites, literally just Google HPTN or HBTN, go to their website, click on studies. It'll tell you, which studies are enrolling. Click on the links, it'll give you a further description. I also know that Project Achieve out of the New York Blood Center here in New York City is enrolling for some studies. And so if folks have questions about those, I have a contact for you all. Feel free to, I can post my contact. I'll post my email. You can shoot me that.
I will also add that, one of the I guess the privileges of my work is that quite a bit of it is international in focus as well. So we're doing quite a bit of work looking at TB vaccines, building off of our work with HIV as well and COVID. So we have a few TB vaccine studies that are launching later this year. And one of them is in adolescents who are living with HIV in sub-Saharan Africa. So very excited about that.
Very excited. Very excited. Awesome. Awesome. Okay. So what I'm going to do, I'm going to take a quick 30-second break, show a commercial from one of our sponsors, and we come right back with this ballroom excellence.
Come on.
Great.
All right.
Step up, prep up to help keep you free from the risk of HIV.
Descovy for PrEP, a once-daily prescription medicine that helps lower the chances of getting HIV through sex. It's not for everyone. Descovy for PrEP has not been studied in people assigned female at birth. Talk to your doctor to find out if it's right for you.
Descovy is another way to PrEP. Descovy does not prevent other sexually transmitted infections, so it's important to use safer sex practices and get tested regularly. You must be HIV negative to take Descovy for PrEP, so you need to get tested for HIV immediately before and at least every 3 months while taking it. If you think you were exposed to HIV or have flu-like symptoms, tell your doctor right away. They may check to confirm you are still HIV negative. Serious side effects can occur, including kidney problems and kidney failure. Rare life-threatening side effects include a buildup of lactic acid and liver problems. The most common side effect was diarrhea. Tell your doctor about all the medicines and supplements you take, or if you have kidney or liver problems, including hepatitis. If you have hepatitis B, do not stop taking Descovy without talking to your doctor. Ask your doctor about your risk of HIV and if Descovy for PrEP is right for you.
Get help paying for Descovy for PrEP. Learn more at stepupprepup.com.
Awesome. Thank you. Thank you. Thank you. Yes, Gilead is our sponsor for the series that we're having, not just today's conversation, but they provided us funding to be able to have this conversation, a bunch of conversations over the course of the year about, about our community and how we can better help each other. We got a comment here. Want to say hello, Stephaun, Tandra.
Hey, Tandra.
And Tandra says call. And anyone else that's watching, feel free to drop your questions, comments, suggestions. We'll get it up on the screen and get these answered. So the next question, we'll go to Tony.
So how do we understand clinical research when it comes to the context of Black Lives Matter and Black Lives Matter, movements?
That's a very interesting question. So, I mean, there aren't necessarily any like clinical research studies, to my knowledge, that like incorporate perspectives of like Black Lives Matter explicitly. I could be wrong. I'm not, the expert of like all clinical research. But one of the things I think that might help you kind of like contextualize or kind of understand is one of the things I'm beginning to see in research broadly, right, with Black, Indigenous people of color, right, globally, are more kind of emancipatory approaches, right? So we can find just research and methodologies, right, that are not traditional, right? I see a lot of intersectionality being utilized in research, right? So actually something that I'm applying to and hopefully I get in is actually a summer intensive and utilizing intersectionality in HIV specific research with BIPOC populations. And I've actually published on in that intersectionality and LGBTQ women of color in sport. And so I think as time goes on, we kind of see some of these things being kind of risen to the forefront by movements like Black Lives Matter, right? Critical race theory to be another theory to, as an example. We'll kind of see researchers kind of trying to find ways to incorporate elements of those theories and praxis into their research studies. One of the things that Dr. Wallace alluded to earlier is about, making sure that our healthcare providers are culturally competent, culturally informed, right? And I think that's something that, is directly related to like the mission of Black Lives Matter, right? And a lot of other, POC-centric movements, so.
I will add that I think that the context of people's lives is important to consider from the design of research, from the very beginning. Before a research protocol is developed, that is the document that really guides how the research will happen from start to finish, that the lives of the people being recruited or being engaged for this research project are considered, that we think about, who we're wanting to engage and how we're wanting to engage them as we think about the language we use in our informed consent forms, as we think about the environments that we're setting up in our clinical research sites. And I would also say that we think about how we approach recruitment and retention of participants in studies. So there are a lot of different ways that I think the context of the lives of Black people need to be considered in the research process. One of the other things that really stands out to me, and we have been talking a lot about this in my organization, particularly in response to the COVID-19 pandemic, is do we set enrollment targets for specific communities so that we are ensuring that we're actually recruiting a sufficient number of people, Black people, Latinx people, Indigenous people, et cetera, within the clinical trial, so that the trial is meaningful and that the data can then say something meaningful about those people when we have it. So there's a lot of ways that I think that clinical research can really be modified in ways that really speak to the lives of Black people, and don't and don't just make them numbers in the process.
Right.
Yeah, very true. Very true. All right. Martez, you had anything you want to add to that?
No, I think
No.
Wallace covered the things that I missed.
All right. So, and this is just a general question. What is the biggest thing people don't know when it comes to race, HIV, and clinical research? And y'all touched on it a little bit, but you could spend some time answering this question directly.
My Lord.
Oh man. I mean, I think this kind of depends on who's asking the question, right, and who's watching, right. I think there are folks who are very well informed, not many, but there are folks who are very well informed about, you know, Black folks or race in general and HIV and clinical research. But then I think there's a lot of things that we don't know, right, and you don't know what you don't know, right. So again, that's why I say it kind of depends on who you ask this question.
I think one of the biggest things, if I can jump in,
yeah, because my wheels are still spinning.
Yeah, I think one of the biggest things, if I can jump in, is that there's a significant amount of misinformation that exists in our communities about, you know, what it means to be Black, and, you know, our susceptibility, or how we might be exposed to HIV and clinical research broadly. And some of this is brought about because of, you know, centuries of abuse of our communities, of folks in our communities, from research experiments that have not been well managed and well designed in the past, including the U.S. public health study of untreated syphilis in Black men at Tuskegee Institute. And some of these experiences, I think, are a part of a narrative, a counterculture narrative that has been constructed by people outside of our community, that has been fed to people within our community in order to further create dissension and divide. And we saw quite a bit of this happening during the COVID pandemic, when there were white groups who were out there literally constructing memes and videos, et cetera, in order to drive Black people away from vaccinations, from clinical trials. And some of them were attempting to recruit Black nurses and Black physicians as part of the process as well. So I think there's a lot of skepticism in our community regarding HIV, regarding clinical research. And I would say for the most part that skepticism is healthy and it makes sense. And it's valid. I would also add that that we can't sit in skepticism, that part of the power of questioning and skepticism is the ability to not just pose a contrasting thought and opinion, but to actually seek perspective and to seek understanding. And I think if we approach it from that lens, then we would all be doing ourselves a great service, not just in terms of learning more about, you know, research, learning more about HIV, but also helping to further understand and create bridges within our community to this process. One of the things I will also mention about HIV, since I mentioned the mRNA vaccines, is that, you know, one of the co-developers of the mRNA COVID-19 vaccine tested in the Moderna trial was a Black woman named Dr. Kizzmekia Corbett. and that there are Black people all throughout the clinical research process. Unfortunately, there's not a whole lot of us, but there are Black people all throughout the process, you know, who are looking at data, who are involved in processes, who are working tirelessly to ensure that the lives and experiences of Black people and other groups who are non-white are being looked at and being carefully considered in these processes. So.
Can't sit in skepticism. I wrote that down. I don't know if you saw it. I looked down. I was like, I'm gonna use that against somebody in a minute.
Yeah, that was eloquently stated.
Yeah. Yes. No, yeah. I don't even have any follow-ups behind that one. Tony.
So, what tools exist now to help clinical trial sites support those coming from the Black experience?
There are quite a few tools. You know, Martez mentioned the HIV Prevention Trials Network, so I want to lift them up for a second. You know, that's one of our sister networks. They created this this cultural responsiveness training called Presence at the Table. That is amazing. That we've also adopted in our organization, and we've also seen implemented in many other spaces. But cultural responsiveness trainings generally in the clinical research context are critically important. There's also the C4 model, which is a model that Dr. LaRon Nelson, one of my colleagues, developed, who's also a researcher with the HIV Prevention Trials Network. And it's a model that literally takes in the lived experiences of Black people in the context of introducing a biomedical product, and recognizing that giving somebody a pill or giving somebody an injection in and of itself is not going to get the result that we're looking for, that we really need to start from ground zero and look at where are people at in their lives, and how are they navigating these systems that are designed to oppress us, and what can we do to mitigate the harms caused by those systems while simultaneously providing them education and opportunities to have different health outcomes in the process. And I'll pause there for Martez.
Yeah. I would just add that I actually had the privilege of working with Dr. LaRon Nelson. He's actually one of my mentors, and he serves on my dissertation committee. On the development of the C4 project, we actually tested it in sites in upstate and downstate New York with a few different institutions. So that was a really, really great project to work on. I was actually going to mention that C4. In addition to things, like C4, this is something that I actually do a lot. I actually consider this part of my service work. Community advisory groups and community advisory boards. There are a lot of companies and institutions and researchers who make use of community advisory groups and boards to make sure that their studies or protocols and study methods are culturally informed and culturally relevant.
Mm-hmm. Yep, very important. Go ahead.
I wanted to add to that, just to underscore a point that I made a moment ago about not sitting in skepticism.
Oh, yes.
And that really we are a tool that can help clinical trial sites recognize and understand the Black experience by holding them accountable.
Yeah.
That we have an opportunity through the various community engagement mechanisms, CABs, community groups, et cetera, to inform the design of these trials, to inform how they're implemented, how they're recruiting our people, how are they speaking to us, how are they engaging us, and how are they involving us in the process. Right. That these are all opportunities that we have as well, and it's really, I think, upon us to also take advantage of those opportunities.
I agree.
There's so many things. Y'all are here dropping these gems, and I'm like, yes, we are a tool, and Stephaun, you mentioned earlier about the Tuskegee thing, because during COVID, that was the thing that I heard brought up over and over. And I got to the also like, y'all don't even know what happened, right? Because it was going off of what someone said or what someone told you, or you read online. And, it's a tough time. I'm going to come back to the COVID. This was supposed to be a COVID conversation, but we're going to come back to that in a second. How can people be informed about advancements in HIV treatment and prevention? I know you mentioned some there, Martez. Do you have any others you guys might want to drop and share with our viewers?
Yeah, I would just say Help End HIV on Twitter and on Instagram is the handle for my organization. And we tweet not just things that are happening within my organization and the research we're doing, but also things that are happening in the field broadly. And there are other groups I know who are doing this as well. If folks are on Twitter, follow like valid, verified handles who are talking about these topics. You know, HIV.gov.
Body Pro.
The Body Pro does amazing work in this area. So there are folks. ABAC is another group that does amazing work and produces community friendly, is what I would call them, materials that are not, you know, laced with a bunch of scientific jargon. So they're
What about you, Martez? You had any others you wanted to drop in?
I was looking at Treatment Action Group was another group that kind of came to mind. So yeah.
The Black AIDS Institute,
Black AIDS Institute,
Southern AIDS Coalition.
So many resources, right?
Mm-hmm.
Besides,
I even follow like the CDC and like the NIH. They have like they have overarching Twitter pages, but then some of the institutes have specific pages. So like, you know, the NIMH, which is the Institute of Mental Health Research. So like there are a lot of sources. Another thing that I suggest is if you're kind of research savvy and you kind of have an idea of like what topics you want to be updated on, set up a Google alert. So go to Google Scholar and set up like a, you know, if there's certain authors you want to keep up with, certain disciplines, you know, certain institutions, you can set up alerts that way too.
Yep. I was just working on some Google alerts right there. But again, so follow verified resources, not YouTube, not a repost of a repost or retweet of a retweet of a retweet. Verified, valid sources is the way to go. Come on, you got anything else you want to add on before I veer off into my rant of COVID and HIV?
Go right ahead, Kenya.
So at the onset of COVID, there was some concerns about resources being taken from HIV work to put into COVID, and that was creating some concerns for folks. Did you find that to be true, that resources was pulled from HIV research and put into COVID, or not?
I represent, you know, I represent one of the global HIV research networks that's funded by the NIH, and I can say that from my experience, that wasn't true in my organization. You know, our HIV studies paused briefly during the earlier part of the pandemic because of safety precautions for the participants in those studies and the study staff. But resources weren't reallocated from our research studies to support COVID-19. And in fact, the federal government wrote blank checks to the pharmaceutical companies to move those products from the different phases of research.
Yep.
Yeah, I would.
Their dollars.
Yeah, I was gonna add. Yeah, like, you know, my experience was not necessarily that resources were reallocated. If anything, in my experience, I received additional resources to buffer against the negative impacts of COVID. In addition to that, you know, I just want to echo what Dr. Wallace just mentioned in terms of studies being paused very briefly. Some folks, if they were able to, they just pivoted to online research. And then what I also saw is I also kind of saw like an expansion in some folks' research interests. So in addition to focusing on HIV and biomedical work, sexual health related things, STI related things, they also incorporated COVID or expanded to examine COVID within those contexts. So
yeah, I agree. I knew that, but I wanted people to hear it from you all, because you all are really there, like hands in. You know, I have to read the great stuff y'all send out an email. Y'all are out there actually like doing the work. So another question I have, and these are all off scripted questions. I'm just going off right now.
Mm-hmm.
You know, there's been a few things, you know, and because I'm thinking about issues that I heard people raise just over the past 2 years. And, you know, they're saying, oh, we got a vaccine for COVID, but we don't have a cure for HIV, for cancers. Could you explain to the folks why that happened and what that means for, and how the advancements in COVID research can lend to those things that was existing before COVID-19?
All right, I'll start, and then Dr. Wallace, you can kind of take over. So at the very, very basic level, like let's talk about like, you know, like disease pathology, right? COVID versus HIV. They're both viruses. The only thing about COVID, right, is it's a lot less, I don't want to say it's less intelligent than HIV, but it doesn't see, we don't see those reservoirs, right, that we see with HIV. The thing with HIV is one of the first thing that HIV does when it gets into your system and it actually infects the white blood cell is it reproduces rapidly. And that excess of virus actually hides in the body. It lies dormant in the body. And so, you know, you can take medication when you get diagnosed with HIV, take medication to reach an undetectable level. Even though you're undetectable, if you were to stop taking your medications, or if you were to experience some type of ailment that negatively impacts your immune system, the virus can then reemerge, right? And in some cases, it can even mutate, right? So it can become resistant to certain classes of medications. Whereas with COVID, even though we kind of see some folks, we see that long haul of COVID symptoms, to my knowledge, and please correct if I'm wrong, Dr. Wallace, that isn't as nearly as detrimental or as hard to treat and target with the vaccine as it is with HIV. And, you know, I can get a lot more complex with, like, you know, the science behind, like, you know, the different mechanisms with HIV vaccines and some of the treatments. But, you know, I don't know as much as Dr. Wallace knows about them. So I'll leave those to him.
I'll pick up there, and thank you for that. I'll pick up there just to say that the target, when we think about a vaccine teaches our body to better fight off an infection. In order to create that vaccine, we need to understand what the sort of target immune response is that we need that will create that protection effect that we're looking for. We've not been able to fully determine what the target is for HIV. We have been able to determine it for various types of coronaviruses. And we've been researching coronaviruses now for well over a decade, closer to 2 decades. And so part of it is we've done so much work in this area around HIV, around SARS-CoV-1, around MERS, and around different strains of influenza or flu that we're able to, from a respiratory perspective, we're able to really know, okay, if we put this with this with this, we know that we're going to get this as a result, and it's going to provide protection. Mm-hmm. So getting to the place of getting a COVID-19 vaccine was in part, one, based on our understanding of coronaviruses that spans almost two decades. 2, because of the sheer coordination level work that was happening within the federal agencies to help move this forward. The fact that there were thousands upon thousands of researchers around the world who all basically stopped most of what that they were working on in order to focus on this one thing. So it's like if you have 100,000 people, right, who just stopped everything else they were doing, you know, temporarily and start focusing on this one thing, you're going to get some answers.
Yeah. Mm-hmm. Yeah.
The other part of this, as I mentioned before, is that taxpayer money went into getting these vaccines manufactured and getting the manufacturing capacity of these developers up well before we got to a phase 3 trial. So this was done at risk, and there are considerations there as well. But the benefit to the American people, and really people around the world, is that the availability of vaccines, you know, we typically don't have millions of doses of vaccines available after a vaccine is approved. It takes time to get vaccines up to that scale. But part of the reason why we were able to do that is because of the investment by the American people to via tax dollars to do that. And then I will also add that the HIV field contributed greatly to this. The HIV Vaccine Trials Network, my organization, the HIV Prevention Trials Network, the IDCRC, which is another clinical research network that focuses on communicable diseases, as well as the AIDS Clinical Trial Group, which focuses on HIV treatment primarily, and they also do some cure research. That it's really the expertise of these 4 networks that came together, right? And these networks were globally that came together that pulled in clinical trial capacity, statistical and data management capacity, community engagement capacity, that really helped to shoulder this. That's how we got here this quickly. You know, typically people assume that it takes about 10 years to develop a product. And under normal circumstances, that's true, because the pharmaceutical companies have to go out and basically raise the funds to go from one phase of a clinical study to the next. However, because they had US taxpayer dollar investment, they didn't have to do that. And so they could literally move from one stage to the next like that. As soon as the FDA reviewed the data and gave the okay, it was on to the next phase of study. So the time was cut significantly for all of these reasons.
And I just want to add also that I think there was a lot of concern around the mRNA technology. However, you know, research on that, you know, started, correct me if I'm wrong, it started back in like the 60s or 50s, right?
mRNA technology is definitely not new. It's new in this context, but it's not new in research, and it's not new in the clinical trial context. So we've been looking at mRNA technology for more than 15 years. So
thank you for that. Thank you both of that. Couple questions I have that I want to follow up. And Martez, you mentioned something about HIV being dormant, right? But could you just explain that to the layperson that doesn't understand what that means or how that presents itself?
Yeah. So if you think about like the life course per se of like HIV, right? The general life cycle of HIV is that it's born right from a cell, right? Or it infects a cell, it produces copies. Those copies then go and infect other cells, right? And that's then transmitted either via sex, some type of exchange with like right in the 5 fluids that transmit HIV, right? And so then the cycle starts over again once they're exposed. A copy of the virus or copies of the virus infect white blood cells. It then replicates, and thus the cycle continues. Early on in the infection, like when the person is first exposed to HIV and it successfully infects a cell, what happens is it rapidly reproduces. Some of that virus will remain like in the bloodstream, visible to other antibodies, and like visible, for lack of a better word, to the medication, right? If you start treatment early enough, but it's a portion of that, and this is why we always tell folks to start treatment earlier rather than later, because the longer you wait, the larger amount of the virus will kind of go and hide, if you will, in your body dormant. And that's why I said, so folks living with HIV, although they can maintain viral suppression, if they were to stop taking their medications, after so many weeks or months, right, the virus would resurge, right? And it's possible that the virus could mutate and not respond well to the same medications they were taking before. Does that make sense?
Oh, absolutely. Absolutely. I got it. It's one of my viewers to get it.
Yeah. But that's an example of one of those targets that Dr. Wallace mentioned, right? So we don't know like where, you know, we have an idea, there's some studies that give us an idea of where the virus hides in the body, but we're not completely familiar around like the mechanisms, right? Like how does it hide, right? What are the what code is in, right, the RNA, HIV RNA, that allows it to hide? So yeah.
Okay.
It does go undetected, and our immune systems are really good at detecting things, and for some reason they're able to go undetected in these reservoirs. And it's complicated, not just the treatment work, but it's also complicated HIV cure work as well.
Thank you. You see, Allison, shout out to Allison. She just said, I learned, because there's always someone that doesn't know. So, Dr. Wallace, I'm gonna pivot to you. You said COVID been around for decades, and you mentioned something about SARS and MERS. You mean COVID wasn't developed in 2019 to get us to take this vaccine so we could turn into robots, which I saw someone say last week, mind you. So tell me about that. What do you mean by COVID been around for decades and SARS and MERS?
So I will say that because I've heard the robot commentary, and I've heard mutant powers, etc.
Yes.
I'm waiting for my mutant powers. I've been vaccinated and boosted, and I would love to be able to control the elements like storm. So
yeah, me too. It hasn't happened yet.
That's what I'm waiting on. But but I will say that know that the virus was not invented in 2019, as in the collective coronavirus family. That the SARS-CoV-2 virus is part of a family of coronaviruses that includes the first SARS as well as MERS and different strains of influenza. So
as well as the cold.
And yeah, influenza. So the flu. So that these viruses all represent what we've been affectionately calling coronaviruses. And part of the reason why they're called that is because the spike protein, if you look at the top of it, it kind of looks like a crown. And it sort of has this corona sort of feature to it. But no, it wasn't a global conspiracy to get people to take vaccines. And I think that there are ways in which that this entire pandemic could have been mitigated, and it did not have to turn out the way that it did if folks in the former administration had made different decisions. But
you mean so they didn't develop it so they could steal the election?
I have to say that I don't think that he's that savvy.
Right. You got a lot more diplomatic than I could.
If y'all think that he did that to steal the election, then you think more highly of him than I do. So.
Yeah, and I was just like, the whole world is in on our election now. Like,
right.
United States thing. This is a global thing. But anyway, don't get me on my soapbox. Thank you both for spending time with us this evening and sharing information. If you had to give one message to the people watching, whether it's around HIV or COVID or vaccines or whatever, what would that one message be? Martez, I'll let you go first.
Do your research. If you're unsure, ask a friend who's a scientist, or ask somebody who you think has access to the information. And if you still don't find anything, right, Google is your friend. Scroll past the ads, of course, right, and actually go to the verified websites, right, like the trusted institutes, right, so like the CDC, the NIH, right. If you come across a journal article or something, make sure that you can look this person up and that they're affiliated with a valid university, a valid institution. So I think there are a plethora of resources available for folks to educate themselves on the internet. If you can't find them, again, feel free to shoot me an email. I'm always willing to have a discussion with folks and answer their questions and concerns around research and clinical trials in general. So,
awesome, thank you. And Dr. Wallace.
We will be still managing long COVID and COVID-19 for some time to come. So I think it's important for folks to one, come to terms with that, and to two, recognize the value that the measures that have been put in place have to controlling the spread and reducing the impact of the pandemic. I'm hopeful that we will get out of the pandemic status and that the disease will become endemic, meaning that it will not necessarily be ravaging the world in the way that it's done so far. But even when the pandemic status is taken off, that this can still make a turn. And so it's important for folks to really think about this for themselves. What does this mean for the context of your lives, your children, your families, your friends, your colleagues, or et cetera? So get informed, get vaccinated if you can, and stay protected.
Get vaccinated and stay protected. Thank you both again for joining us tonight to not only show Black excellence, but show ballroom excellence. Because y'all are parts of the ballroom community, just like all of us. So thank you, thank you, thank you, thank you, thank you. Anyone that's watching, if you have any questions that, if you're watching this later and it pops up, shoot me a message, shoot me an email, comment on the page, and I'll forward it to our esteemed guests to get you all an answer. Have a good night, everybody.
All right, thank you.
Have a great Marc Jacobs evening.
Have a great March. All right, have a good night, everybody.
Take care.